Pharmacy Workforce Lead based in Hampshire and Isle of Wight, and on behalf of the South East Pharmacy Workforce Leads, we'd just like to welcome you all to this webinar on introducing advanced practice for pharmacists, which has been done in collaboration with the South East Faculty of Advancing Practice, and we've also got some great speakers lined up for you today, for those that are working within ACP and advanced practice areas. And we've also got representation from the Royal Pharmaceutical Society today as well. So hopefully this will be a really interesting introduction for you all and provide you with the necessary information. We'll have time for some Q&As at the end. If you can keep your mics off throughout whilst the presenters are presenting, please feel free to use the chat. Members of the team will be keeping an eye on the chat and collating any questions that they may have. We'll also put this recording onto YouTube and send out a link. And any common themes that we identify as questions that are coming up, we will aim to produce an FAQ document after this session as well. So I will just share my screen. Is that sharing okay?
Perfect. It's on the presenter view, so we can see your next slide.
Is that better?
Oh, yeah, perfect. Yeah.
Very much. Okay, so I'll just go through a brief introduction today, and I'll just introduce our speakers as well. So we've got Claire Thompson, who's the training programme lead for advanced practice for pharmacy based in NHSE South East team. We've then got Sosan Saba, who's the lead healthcare at home pharmacist. We've got Andrea Wilson, who's an ACP and pharmacist partner at St Richard's Road Surgery. And we've also got Rachel Lewis, who is a curriculum development manager, assessment and credentialing at the Royal Pharmaceutical Society. As well as that, on the call, we've got, as I mentioned, the South East Workforce Transformation Leads. And here's our mugshots. So our roles look at pharmacy workforce as a whole across systems. So we're all based in geographies across the Southeast. So feel free to reach out to us following the webinar today should you require any further information around advanced practice. Our programmes of work look at pharmacy across all sectors as well as the geographies, and looking at all areas of practice from early careers right the way up to consultant level as well. Our contact details are on the slides. Okay, so a bit of audience participation to start off with. Just going to put the QR code there for you to log into Slido. One of the common questions that we get asked all the time is advanced practice versus ACP. And my slide has just crashed. If you just give me a moment. Clearly there's too many people on this webinar and my Wi-Fi is not letting me go into the Slido. So let's go to plan B then. If you can put comments into the chat, it's just so we can gauge as well what's kind of everyone's thoughts around advanced practice pharmacist versus advanced clinical practitioner. So what is the difference? We've got quite a few comments coming through. So ACP is a recognised role in primary care. ACP can be from different backgrounds. ACP can have a patient caseload. Advanced practice pharmacists may not be clinical. Hoping to find out more to this question. ACP is a qualification. Lots of interesting comments in the chat, and yes, we will unpick this as we go through as well. Hopefully we'll be able to give you your answers. Okay, so advanced practice is a continuum of practice, and as you move through your career journey, you may find yourself going through a non-linear journey, and some of our colleagues will talk about their experiences with that today. So entry level of practice or early careers as we know it, moving on to enhanced level of practice, and then advanced. And they are very distinct. Enhanced and advanced are very different, and so is consultant level. You also may find that you are more dominant in one pillar over the other, depending on how you specialise in your career going forward. And equally, you may also end up going back up and down the continuum, depending if you change roles or sector throughout your career. So it's a journey, and actually moving up through it and around it and using the frameworks that are available are a way that we can govern what advanced practice truly looks like for the pharmacist profession. So a bit of background to this then, why we're looking at advanced practice with a closer lens at the moment. So you're all aware of the NHS long-term plan, which highlighted particularly the roles around advanced practice and the ambition to continually increase the numbers. So we are expecting the revised edition of that coming hopefully in the next few months, depending on the government. But definitely advanced clinical practice was highly specified within this, and the ambition to grow across the 4 pillars. Coupled with that, we have the multi-professional framework for advanced clinical practice, which I believe some of you have referred to in the chat, with the fact that advanced clinical practice framework is for all professions. The other thing to mention is the 4 pillars as well, which colleagues will go into in more detail towards as this presentation continues, because it's really important that we don't just focus on what we tend to, which is the clinical pillar as well, but all have equal weighting. We also know that the government ambition with Darzi is the left shift, so we will see hopefully a move within some really exciting roles within primary care, local care and community around this as well, particularly with the shift of out of hospital care, and also with digital analog to digital as well, and we should see changes of how we use our services going forward. And advanced practitioners will be really embedded as part of this, but it's not everyone's responsibility to become an advanced practitioner. Enhanced is also equally a really good place within your career to be, and actually that's how you start those conversations with your employers going forward as well. And sometimes people forget the enhanced level, I think, before moving to the advanced stage. So in terms of education development then, this kind of diagram shows something that we're all probably familiar with. You start with your degree and you're a novice practitioner, and then you transition and you move through. It is a Venn diagram, it is a continuum, and they do overlap as well. You may find your strengths lie in one pillar over the other, and then the hope would be, if that is your aspiration, to eventually move to consultant practice. So the 4 pillars of advanced practice, as I mentioned, we've got clinical, leadership management, education, and research all have equal weighting and all are requirements of the curriculums and the frameworks around advanced practice, whether you go through a university route or whether you go through a portfolio-based route. And again, colleagues will talk about that in more detail as we go through. Okay, and that's it from me as the introduction, and I'll hand it over to Claire.
Hi, good afternoon, everybody, and thank you so much for joining our webinar today. So as Anne-Marie mentioned, I'm Claire Thompson and I work for NHS England 1 day a week as the training programme lead for Pharmacist Advanced Practice. This was a new role that I started in September and hopefully shows the ambition that we have for pharmacists to obviously progress in their careers and as Anne-Marie has mentioned, go through that continuum. So super excited that so many people have joined today and hopefully we can continue the conversations after the webinar. So what do I do or what do we do? So each region within England has a faculty of advanced practice, and this was born out of the NHS long-term plan and the long-term workforce plan to try and drive forward this agenda of having advanced clinical practitioners within the NHS. So it's a, next slide please, sorry Anne-Marie. So we obviously cover the whole of the Southeast and the team is made up of, if the slide moves on.
Surgery is your patient, the one you talked about.
Oh, sorry, just pop yourself on mute there if you've just joined, please. So our team is made up of a faculty lead, Sarah Goodhue, and then we have a number of members of the team that support her. So we have a lead for supervision and assessment. The majority of these are nurses actually by background. So Sarah was a critical care nurse by background, outreach nurse. Karen was originally in primary care. Emmy is our project lead and we've obviously got some support. And then alongside that core team, there are a number of multi-professional training program leads, and this has probably been alluded to in the chat already, that advanced clinical practitioner could be from many different clinical backgrounds. So I'm employed as the pharmacist lead. Like I said, this is 1 day a week alongside I have a very busy clinical role within primary care, leading a team of pharmacists within a PCN, as do my other colleagues. So we have representation from other backgrounds as well, whether that be paramedic, radiographer, nursing, etc. So it's definitely multi-professional, and I think it's good to think of pharmacy as a member of the kind of wider MDT family when thinking about advanced clinical practice. Next slide, please, Anne-Marie. What is the purpose of the faculty? What do we do? So as well as obviously trying to drive forward the ambition of increasing the number of advanced clinical practitioners, we standardise or support the standardisation of approach to advanced clinical practice, primarily through accreditation of courses. It's obviously to ensure there is a standard level across NHS. We obviously provide recognition for practitioners, whether that be going through a course or recognition with the digital badge, which I'll go on to discuss later. And as a result of that, we have a lot of key relationships. Next slide, please, Anne-Marie. So we support individuals and trainees. All applications to go onto an ACP training route have to come through the faculty team. And there's an annual window when that is open. It's open currently at the moment for March, and that's for new practitioners who will be starting this September. So all applications vetted, scrutinised, so to speak, to ensure that there is that governance in place. And we obviously support all those trainees that go through the portfolio route as well. Above this, obviously, we support employers. So this is actually about workforce transformation. This isn't necessarily about an individual saying, oh, I'd like to do this. You do need to have the support from your employing organisation. And it's how are they going to transform the workforce in that area service wherever you are working. And like I said, the faculty accredit programs. So there are only a number of universities that have accredited programs for advanced clinical practice, and that's to ensure that kind of standardization, governance, and that all the trainees are appropriately supported. Next slide, please, Anne-Marie. So Often people want to know about funding. How does this work? If you are wanting to or interested in the advanced clinical practitioner route as an MSc. So as it currently stands, like I said, there is a funding window that opens once a year, which is currently open now for March. So obviously people on this call would be more eligible for next year, because this is something that would take time to work up with an employer if this would be a route that is suitable for you and for the team that you're working in. So you would be, or an individual or an employer would be given the funding to pay for the tuition fees for 3 years for that individual to transform from a trainee into a recognised advanced clinical practitioner. And there's also, in addition, a kind of supplementary grant that's given to support the employer with the education and training element. So obviously we recognise they will need supervision in practice, and it's essentially money to support that, whether that be supplementing backfill for a more senior colleague who will be a supervisor, or to allow other time, to allow more supervision essentially. So most trainees would enter at the start of the ACP route, which is, like I said, 3 years. The modules will be slightly different depending on the HEI that you sign up with, but there will be core modules within that, one of which is prescribing, which majority of pharmacists may have now done prior to starting an ACP training group. You could not APEL over diplomas in clinical pharmacy or anything like that. The only thing that would be recognised is if you've done a postgraduate diploma in actual advanced clinical practice. And this is to assure, again, the kind of standardised route, because this isn't just about pharmacists who've got a particular background, it's multi-professionals, so it's to ensure the same standard at entry. There is also an apprenticeship route, which is slightly different, but majority of people tend to, and those who will be speaking shortly, go through the ACP MSc route if appropriate. Next slide, please. And who's eligible for funding? And like I said, the money would go to an employer. So if you were to change roles, that doesn't mean that the money would continue with you. The money, if approved, would go to your employer. But how do you get this money if you want to become or have an MSc in ACP? There needs to be an identified need. So like I said, this is about workforce transformation. So your employer needs to have a case for, we would like an advanced practitioner. What will that advanced practitioner be doing, and how are we going to evidence they'll be working across the 4 pillars of practice? So I think a lot of people, and I'm sure a lot of us, work with historical ACPs who are purely clinical, but the 4 pillars of practice is fully embedded within the long-term workforce plan agenda. So any job plan that's submitted for consideration for a training position would be looking for how are we going to ensure that they're working across the 4 pillars of practice. So the individual would need to be in a trainee post, which will then obviously develop into a full role at the end of the course. They obviously need to have the right, correct learning environment and appropriate supervision in place. So that would also need to be submitted to the faculty with a clear name supervisor. There is a little bit of flexibility that you can do it slightly less than full-time working, which is great to see. As discussed, there are some apprenticeship routes available, but the funding is different. And there needs to be a kind of readiness for action, really. A checklist would need to be completed, and then the faculty do check in with the trainees at every 6 months to see how things are going. So it isn't really a case of, oh, I've got this money and I'm going to go off and do this course and do it whatever I want. It is quite rigorous and regulated, because obviously it's a significant investment from NHS England. Next slide, please, Anne-Marie. So as I said, there are requirements. You would be signed up with a university. So obviously there's some requirements there of what your degree needs to be prior to joining. And as I said, you would need to have a job plan, that there's minimum supervision requirements included within that, allocated study time, which is what some of the extra funding is given for, to allow for that and to allow that backfill to happen if needed. But clear plans of how it would be achieved, and what will the transition be from a trainee into a fully qualified ACP, and how that will develop over the 3 years. Next slide, please, Anne-Marie. Currently within the Southeast, a number of universities are accredited, which is great. So hopefully across the region, we've got good representation there. There are a couple there actually also in London, some which are more relevant for a particular paramedic course that runs. But yeah, so a number of courses are accredited within the region, which is great. So hopefully those are reachable for people in different areas of the Southeast. Next slide, please. And I'm going to hand over now to Sorsen to talk about her experience of being an ACP trainee, and I'll speak later about the portfolio route. Thank you.
All right, thanks, Claire. So thanks for having me. So my name is Sosin Sabah. So I'm the lead healthcare at home pharmacist at Medway Hospital. I'm here to talk to you about becoming an advanced clinical practitioner. I'm almost an ACP. I've got my Viva in a few weeks, so I'm almost at the end. So I'm sort of in a position where hopefully I can provide you with some tips and tricks from my journey. So moving on to the next slide, Anne-Marie. So, you know, I graduated in 2011 from Cardiff, and since then I've just had, I've had the pleasure of working with some really amazing organisations, whether that was Bristol, a few teaching hospitals, so Cambridge and Oxford, and then I decided on applying for a job in Hampshire hospitals as the frailty lead, and split with that role. I was also working and employed by the University of Reading, so I was split within the week between Hampshire hospitals and the University of Reading, and quite frankly that was quite possibly the best job move I could have ever done, and I'm obviously forever grateful to actually Anne-Marie for asking me to apply for that job in the first instance. So Anne-Marie, next slide. So whilst I was in my role as a frailty pharmacist, that job description as a frailty pharmacist, it was a new service. The frailty team was a new service, and that job was also new. So within that job description, there was actually nothing in there about advanced clinical practice. But I decided to become an advanced clinical practitioner. And the reason was because the more that I worked and the more that I saw patients and the more that I realized that within frailty, I needed to prescribe, I also needed to de-prescribe, the more I realized that there's a much bigger clinical picture out there. And actually, I needed to start as a practitioner, I needed to start taking all this whole bigger picture and this whole story into account when making these prescribing and de-prescribing decisions. I also, as an individual, just wanted to have more autonomy to be able to take these factors into consideration and then implement my own clinical plan. The other reason why I decided to become an ACP was actually I realised that the frailty service needed it. So we were a frailty team that at the time did not have any medical input. So this was when I first started in 2018. There was no medical input whatsoever from a junior doctor, now resident doctor, or a consultant. So actually as a team, we really needed to start upping our clinical skills to be able to work at the front door and to be able to do the job that was expected of us. So I actually chose to approach the frailty team, who agreed to fund me from actually the medical CPD budget. So I wasn't funded via the HEE route. So I actually was able to, instead of being within that strict pathway of you have to do this course at this time within this period of time, I was able to choose when I do the modules and at what time. And quite often I was just choosing to do two at the same time, despite the advice that was being given to me from people like Anne-Marie and my line managers not to do more than two courses at the same time. What I liked about it was the flexibility. I was, again, able to choose what I wanted to do and when, but obviously I was maintaining my portfolio throughout that time. So what did training as an ACP involve? So if we go on to the next slide, I know Anne-Marie and Claire have talked about the 4 pillars of practice. So by now you probably have realised that there's 4 pillars of practice. There's expert clinical practice, leadership and management, education, training and development, and research and evaluation. Now, from an academic perspective, what this involved was courses that aligned to each of those 4 pillars. So academically, I was expected to sign up to modules for certain periods of time. So for example, for expert clinical practice, the core modules were non-medical prescribing, advanced history taking and physical assessments, and diagnostic reasoning. Non-medical prescribing is obviously 6 months, and then the other two were 3 months. And within those modules, you're expected to undertake, obviously go on study days, undertake various assignments, stick to deadlines. There was OSCEs. So for example, the advanced history taken and physical assessments had OSCEs, and you were also expected to undertake a lot of learning and practice and evidence that when then completing your portfolio for these modules. In terms of education, training and development, there was a 3-month course related to transition to advanced practice, and that involved doing, for example, a QI project and various other deadlines and assignments to prove that you are working towards advanced level practice. Leadership and management was another 3-month course, and that was all about transition to advanced practice. And again, that was the same as education, training and development. And then there was the research element. So the research element was 1 year, and this was then the final bit of that MSc, and this is the bit that I'm almost completing. So these are the core modules across those 4 pillars of practice from an academic perspective. From a practice perspective, you are not just expected to work and do these academic courses. You have to translate these academic courses into your practice. So if Amarine goes on to the next slide, whilst doing these courses, my practice evolved quite significantly. So the purpose of this slide is really to show you how I went about developing my own ability to work across all 4 pillars of practice alongside the academic work. So again, it's really important that the ACP training and that academic training aligns to everything within your own practice, whatever you're doing or what you intend to do within your own practice. So from a clinical perspective, I actually became and developed as an expert within the frailty arena. So I was taking frailty referrals from the internal hospital, but also from our community partners, and actually working across the sector. And this wasn't just looking at drugs, it was looking at more wider than the drugs and coming up with care plans, whether they were clinical care plans or non-clinical care plans to support our frailty patients across that frailty pathway, again, whether it was in hospital or in community. And because of my enhanced clinical skills, I was able to have quite a high degree of clinical autonomy when seeing these patients. And yes, I worked in a collaborative way with our geriatricians and our consultant nurse, but actually there was a high level of clinical autonomy because of that expert clinical practice. So because of that clinical autonomy, I used that clinical autonomy to set up clinics. And I make it sound very easy. I was just able to set up clinics, but there was a lot of negotiation that needed to happen for me to have this end result of having a clinic. And that took a lot of leadership skills, a lot of understanding the operational side of things and understanding the wider frailty vision. But the end result was I was able to set up my own deprescribing clinic, and within those clinics, I was able to physically assess patients, request diagnostics, and come up with clinical and non-clinical treatment plans. I also decided to set up a joint clinic with one of our neurologists to create a neurogeriatric clinic, and this was also including individuals from the community that I managed to bring into that neurogeriatric clinic. I set up a weekly frailty MDT with one of our local GP practices, and within this forum, people within primary care would join, whether that was the GP had to be there, so a GP, someone from urgent community response, and also the district nurses and someone from social care, where then frail patients will be brought to that forum and then discussed, and plans would be made, so clinical plans and non-clinical plans would be made for that patient, and then we would follow them up the next week. So this work was clearly using my clinical expertise, but again, it involved a high degree of leadership and management skills. From a pure leadership perspective, I I wrote guidelines. There was so much governance work. I came up with cost improvement projects, and these cost improvement projects were pulling from my clinical expertise. So, for example, using deprescribing as a potential cost improvement project, because you're getting rid of a lot of drugs, and how much money can we save through stopping drugs, for example. And also I was a stakeholder in the wider frailty strategy. So this was from a leadership, management, operational perspective. So if we then go back to the left of the screen, so the box at 9 o'clock, my clinical expertise was then used to further the education of others. So whether that was providing teaching and mentorship at a local level to a variety of professionals, doing regional work and regional teachings, for example, with Health Innovation Wessex, or teaching the specialty registrars within the region, presenting at conferences, but also working on a national level and co-writing the National Frailty e-learning programme. And it's really important to note that all of these things were things that I went out and sought myself. They're not things that I just waited to come my way. I was very proactive. I was the one that emailed Health Innovation Wessex. I was the one that sought out these opportunities to spread my education to benefit the education and development of others. Whilst doing that, I was also focusing on my own personal education and my own personal training needs. And over that time, I also trained to become a fellow of the Health Education Academy. Now, from a research and an academic perspective, I published twice and undertook multiple research courses external to those expected from the ACP training. So, for example, I took a statistical course at Imperial University to learn more on how to apply statistics to healthcare, whilst also learning how to analyse those statistics and make them valuable for healthcare. And then from a purely research perspective, yes, from an academically, I was expected to undertake an MSc in a research project, but I proactively applied at the same time to do an NIHR internship, and I reached out to experts within the field of frailty and research to ask for their collaboration and support with my research project. What I'm planning now is a PhD, and I have support regionally and nationally for my PhD, and I'm also typing up my consultant portfolio. But what's important to note that the consultant portfolio is not a given when you do ACP. There is a distinction between being an ACP and being a consultant pharmacist, and I think that has already been covered or might be covered later on. So again, there is a difference between ACP and consultancy, and it's really important to know that difference. But this is how, from a practice perspective, I supported my development across those 4 pillars of practice. Now, tips and tricks, if Anne-Marie moves on. Tips and tricks. You know, I don't really think I'm I'm an expert, but maybe I'm a little bit further in that journey than some of you guys on the call. So hopefully I can give a few tips from my own journey. Now, if you would like to train as an ACP, I would probably say your very first priority is identifying whether the area that you work in actually needs an ACP. So, for example, if I just wanted to work at a ward level as a pharmacist and do ward jobs, and these jobs are so essential, it's really important that not every pharmacist trains as an ACP. We really need to have ward level pharmacists. But if that is your intention, then you have to question whether you actually need to be an ACP or not, because there's plenty of doctors on the wards, and my own job description as a wards-based pharmacist doesn't really have any space for the development of an ACP. So you then need to question whether there's more of a scope for you being an enhanced level pharmacist, so working at that enhanced level of practice instead of that advanced level of practice. So understand your area of practice and understand whether an ACP is needed or not. What's also important to understand is your value. So as a trust, they're investing time and money into your training. So this is obviously the cost of courses, the cost of study days, but also the time that they are taking to provide that learning within a clinical environment. So you have to be able to have open conversations over what you're going to be able to give them in return for that. So for me, I was able to have those conversations where me saying I can save you money through using my skills to deprescribe, using my skills to come up with cost improvement projects, so I can save you money, but I can also generate money for you. So the generation, generating income is done through setting up clinics, and I wouldn't be able to set up my own deprescribing clinic if I wasn't an ACP. And also the generating income is through the NIHR internship. So you have to really work as I suppose a two-way street. So yes, they're invested in you, but what can you give them back that will also provide value to the trust? Um, it's also really important to ask yourself why you want to be an ACP. So again, if your ultimate goal is to work within the SMT, so the senior management team, then I would probably say ACP practice is not for you. ACP is perfect for those that want to remain clinical, but to really branch out and become more autonomous in their clinical practice, whilst also developing their other pillars of practice. And regardless if you want to be an ACP or not, you have to understand whether being an ACP fits with your team vision or strategy. So yes, it's important to voice and say what you want. You want to be an ACP, but that might not be where your team and your strategy is heading towards. So, for example, the frailty strategy was moving towards becoming an ACP service. So this is where you can say, well, I want to be an ACP. You guys are moving towards an ACP service. Let's work together to come up with something where we can both benefit each other. So always make sure that you can align yourself to your team's vision and strategy. I also would strongly advise you guys to have a really strong circle of people around you. So I was really lucky to have mentors, both internal and external to my trust. And these individuals have also become great friends and people that I know that I can rely on throughout my career moving forward. But you also need advocates. So you need people who are within your senior leadership team who advocate for your role of becoming an ACP pharmacist and recognize the value in that. And these are the people that you really need to work with and tap into for them to see what you can achieve as an ACP pharmacist. Because if you can show them what you can achieve, they will become your advocates and push forward that agenda for you. One of the things that really helped me is it actually ensuring that I had the right people within my annual appraisal. So a lot of people approach appraisals as these tick box exercises, but I made sure that my mentors and advocates were within my appraisals. So within these appraisals, I made my career plans quite clear, and we would discuss on how I would achieve those plans. So actually, I transformed my appraisal into these boring tick box exercises that people just want to get over with a more 360 review and a vision for the year that was to follow. So prior to my appraisals, I would map my strengths and weaknesses against all 4 pillars of practice and talk to the people within my appraisal forum on how to strengthen my weaker pillars. And it's important to note that sometimes you will have pillars that are that you're better at than others. You can't be working on all 4 at the same time, but I would use these appraisal discussions to build my job plan, but also change my job plan as my practice evolves throughout the year. And finally, training as an ACP, I'm not going to lie, it is hard work, both academically and in practice. So once you are a qualified ACP, the expectations that the team have of you are quite high. So it's really essential that you are proactive, you're able to create your own opportunities and take opportunities, and you're ready for the hard work. And that's it from me.
Thank you, Susan. And I'll hand it over to Andrea.
Hi everyone, I'm Andrea. I'm a pharmacist at a GP practice in the southeast, in Deal, sort of near Dover. Can I have the next slide, please? So my background is mainly in community pharmacy. I qualified in 96 and then did a stint at Mason Hospital, and then found that because of family commitments and things, I wanted to really be in community. But actually it was a really good move for me because I worked mainly for Paydens, who's a local multiple. Where I work, we've got about 100 pharmacies, and they were very proactive in setting up new services. And the main thing that they started was a pharmacy-based anticoagulation service, which we started from 2010. This really sort of got me sort of branching more out into a lot more sort of clinical practice. And in 2013, NICE decided that rather than prescribe and supply warfarin on the PGDs, that we should all actually be prescribers. So this opened the opportunity of actually getting my independent prescriber qualification. Obviously, I did need a DP, and I approached the local practice that I'd worked next door to for many years at this point, and they agreed to support me with my prescribing qualification. And I then completed that in 2016, and it was quite opportunistic as well because they were just starting a pilot for getting clinical pharmacists into general practice, and the surgery also was involved in that scheme, and they were keen for me to join them. So as soon as I qualified with my independent prescriber qualification, I joined the surgery. So I've been here since June 2016. And it's a very proactive, supportive practice, and they very much like to encourage upskilling the workforce. So they were always looking for opportunities. And the next thing that came along was the Advanced Clinical Practice Masters. It was not just myself, there was also a paramedic at the practice that also went onto the programme, because they wanted to develop our clinical skills and to make us more sort of autonomous practitioners. My route was slightly tricky in that I had to apply for the modules individually initially. Each module I would need to apply separately for the funding to the local training hub. But then eventually, I think after I'd done 2 modules, I applied for the funding for the full programme, and I was awarded that. To actually apply for it, I had to do an essay and then to attend an interview. And then I got on the full programme, which I completed in January 22. And then as of October 22, I was offered a partnership with the practice, and that's what I'm now currently doing. Cover the next slide, please. So my role developed very much over time. When I first came into practice, it was a very new role. So it was very much sort of finding my feet about what I was going to be doing. Initially, it was very much doing minor illnesses, carrying on with my anticoagulation clinics. But COVID sort of changed things, and sort of I was almost at the end of my programme when that sort of hit. So that did delay my programme a little bit. So it actually took me 4 years to complete my ACP Masters rather than 3. But it sort of really changed the landscape of what we were doing as well and how we were working. And the decision was made to for me to go more into long-term disease management rather than doing minor illness. So now we sort of tend to send most of our minor illness appointments either to like the Pharmacy First service or to the urgent treatment centre, and we tend to try and just deal with the more complex patients. And obviously long-term disease management is a huge part of what we need to be doing and focusing on, and how we can improve patients' health in the long term. So now my role involves hypertension. That's going right from diagnosis, all the follow-up monitoring and assessments, referral if needed, lipid management. I still do some anticoagulation and advise generally on anticoagulation. I get involved quite a lot with pain management as well, particularly where patients are maybe been seen by a pain clinic and they've got quite a complicated reduction regime that they want to be doing. And obviously that needs a clinician to actually be supporting the patient with that. So I generally tend to manage that. General medicines advice for clinicians and patients. So before I joined the practice, any medication query would have to go to a GP. Now I actually line manage the prescription clerk team at the practice, and I also have a pharmacy tech as well that supports me. So all medication queries come into our department. If the prescription clerk can deal with it, that's fine. If not, then it goes to the technician. If the technician can't deal with it, then I deal with it. And so there's very few that then actually need to be passed on to a doctor. I also do a lot of audits in terms of prescribing, updating guidelines. So my role is very much sort of 50-50 patient facing and admin. So I do clinics with patients for anticoagulation, hypertension. I still do some minor illness to try and keep my skills up as well. So locally we do additional winter access appointments. So this Saturday, for instance, we're open for enhanced access. So I'm also doing a winter access clinic alongside that. So that'll be for any sort of minor illness. There's also a strong leadership role within the practice, and that's not just as in managing people, but actually leading by example, thinking about new ways of working, trying to look out for opportunities, and just sort of listening really about things that people notice within the practice, about maybe way we can do things a bit better, more efficiently, differently. And in terms of education, I'm a tutor for a foundation pharmacist. They're based at a local hospital, and they go there 3 days a week, and they come to me 2 days a week for 35 weeks of their programme. And I've just been approached by a local School of Pharmacy to be a DPP for the new pharmacists that will be coming out next year. Next slide, please. So reflecting on my ACP course, I think initially it was very much thought that I would be doing a lot of minor illness, which I don't do now, but that isn't really a problem because you still need to use all of your skills because like Sawsons was saying, it's about the holistic management of a patient, not just about medicines. I found it definitely built my confidence, made me a more autonomous practitioner, helped me with my decision-making skills, basically building confidence in your knowledge base. And basically that helps also obviously with all the patients and empowering the patients as well to help look after their own medication and health. Again, it's not just about clinical skills. There's a big focus on clinical skills within the AC programme. There's education, leadership and research. So always looking out for opportunities for research within the practice. So there's the Kent Surrey Sussex Academic Science Network that quite often have opportunities available, so you can reach out to them. So we had one recently where we were looking at checking 1-year-olds' lipid levels to sort of identify people that might possibly be at high risk of early cardiovascular disease with very high cholesterol levels. So that was quite an interesting one, but there's lots of things like that, and that sort of fits nicely with my sort of very cardiovascular focused scope as well. But there are different opportunities out there to get involved with. I don't use all of my skills at the moment because I'm mainly doing long-term disease management, but that's also why I then try and do some of the acute appointments where I can, just to try and make sure that I don't de-skill myself. The other thing is about having a careful consideration about what your scope is going to be, because when you actually do your prescribing, it needs to be very focused, but then you need to think about how, when you've actually got that qualification, how you're going to expand that. So what other courses or training you might need to be able to sort of, so for me, for doing the hypertension, I did a course on hypertension management. I then looked at all of the guidelines and created a protocol for how I would manage the patients, which I then presented to the GPs for their consideration to check they were happy with what I was proposing, and then just gradually sort of building. But you just need to think about how you're going to do that and what you need to do to actually show your competence within those areas to be able to actually expand your scope. And when you're thinking about expanding your scope, you really need to think about your workplace. Where can you actually make an impact? Where is there maybe something lacking that is needed for patients? And how will advanced practice actually help you with that aim? Next slide, please. When applying for the funding, you do really need to be clear that you do understand what advanced practice is, and actually how gaining that qualification will directly benefit your patients, because that's really the main focus at the end of the day. It's how the education and training is actually going to ultimately impact on the patients and the patients' journeys. So that's really what you need to be focused on when you're applying. Do not underestimate the time you'll need to study. It is a lot of work. We were given 1 day a week out of work to actually work on our course. Some days we were actually at university, some days we'll be at home working on essays, etc. But you really need to make sure that you've got the full backing of your workplace and that they understand the time that you're going to need, and that is actually set there before you take on the programme. Also having other practitioners that are actually maybe doing the course, or that you can tap into, maybe go and see if you can sit in with them on a clinic and sort of get a bit of what they actually do. When me and the paramedic were doing our training together, as we were getting towards the end, we then actually started running joint clinics together. So 1 week I would run the clinic, the following week paramedic would run the clinic, because the paramedic had very good, strong clinical assessment skills, and I was very good on medication. So we sort of complemented each other and we could learn from each other as well. And that worked very well. And we did that for about 6 months up to when we finally qualified. It would definitely be good to get some more pharmacists on the ACP course. When I did my ACP course at Christchurch in Canterbury, I was the only pharmacist on the programme at that time. Within my cohort, everyone else was either a nurse or a paramedic. So we need to get some more pharmacists onto these programmes. I think that's it. Thank you.
Thanks, Andrea. In the interest of time, just a reminder, if you've got any questions, pop them in the chat, because we may not be able to do a full Q&A, but we will answer all the questions separately. Just to pop yourself on mute, Andrea, if that's okay. Thank you. Very quickly then, I'll just quickly kind of do an overview of the portfolio route, but also kind of who I am and what my background is as the TPL for pharmacy. So I became an independent prescriber in 2015. I was really fortunate that I had a role embedded within a heart failure team. So this was at Guy's and St Thomas's Hospital in London. They wanted a pharmacist in the team, and it was essentially a bit of a blank page of how I could develop that role by setting up clinics and having a kind of medication review service. As part of that role, I started to realize that I was not so good on some of the kind of assessment skills that our colleagues have just mentioned. So I did an individual module in clinical assessment skills, which is part of the wider MSc, but at that time I didn't even know what advanced practice was. And similar to Andrea, I was the only pharmacist on that module. Everybody else was a nurse at the time. So I think they were quite surprised a pharmacist was even touching patients, let alone managing to pass the OSCEs and things. And then I moved into primary care just a few years ago because I wanted to broaden my experience in cardiovascular and cardiovascular prevention. That's what I do now primarily. So I guess for me, I was interested in being an advanced practitioner, but I felt with 2 children at home, going onto a course, doing an MSc was probably not going to be viable. So I was super excited when the then HEE announced they were going to provide a portfolio route, and this is essentially what I did in 2022. So I completed it alongside the RPS credentialing as one of the first cohorts, and I now have a digital badge as an advanced clinical practitioner. And I guess part of my role is to encourage others to, look at routes, look at opportunities, decide what might be best for you and your personal circumstances. Next slide, please, Amarine. So the purpose of the portfolio route is a recognition route. It is not a training route. It's for people who may already be working in an advanced clinical practice role. It would obviously require employer support. The centre advice is that this should be done within over a 12-month period. The pilot that happened with CPP and RPS was quite fast, and I actually had to gather all my evidence in 3 months, so it was quite tense at the time. But fortunate that I obviously passed first time around, which was great. You do get linked in with an education supervisor, and obviously you get the digital badge at the end. So annually, there is an allocation for those who want to do a portfolio route, and regionally our allocation is 100, and that obviously covers all professions, not just pharmacy. Next slide, please. There's an expression of interest form if you would like to be considered for applying for the portfolio route. It runs continuously. We are advising people at the moment that it can take up to a year to be allocated a place on a cohort. But I think my advice is use that time because then when you are allocated, you should be kind of good to go. So use that time. You know, is there a pillar here that I'm probably not going to meet and I actually do need some training in? Okay, so use that time. Get up to date, use other CPD money if that's available, speak to your employer. Can I start to gather more support in that area so that when I am accepted, hopefully onto the portfolio route, I'm already in a position to say, yes, I can evidence all 4 pillars of practice, because I think that's the training gap for most pharmacists. It's probably research, possibly some of the leadership as well. So if you do think about, I'd like to go through the portfolio route, great, but start looking at what's my learning needs analysis and what gaps do I have and what can I be looking at the moment, because once you're accepted, you cannot defer, and it needs to be done within that year timeline. Next slide, please, Anne-Marie. So the options for pharmacists, that was originally a pilot via RPS CPPE. There were 300 places, they all got filled. The capacity has now reduced, but when you do apply for the portfolio route, it does give you an option of whether you want it to go through RPS CPPE or the centre. Obviously, if you do the RPS credentialing, you would not be eligible for the advanced practice badge or the NHS digital badge. Thanks, Anne-Marie. I will hand over to Rachel very quickly because I'm conscious of time.
Hello. So I'm Rachel Lewis. I'm the Curriculum Development Manager at the RPS. So this is just a very quick summary of some of the RPS things to do with credentialing. So this slide just shows you the different levels of credentialing that are available within the RPS framework. So there's the Post-Reg Foundation curriculum and the consultant curriculum, and in the middle is the core advanced curriculum, which is the one that you're kind of focusing on today. There's also specialist advanced ones for mental health and critical care, which are add on to the core advanced ones. So anybody who's done the core advanced one and wants to go back and add in a specialist mental health and critical care can do. If you're considering RPS credentialing going forward, you can do the core advanced and you can add on the mental health and or the critical care at that time. But it just shows that as you go up, it's an e-portfolio route. And as you go up from post-reg foundation towards consultant, there's an increase in autonomy and complexity of the role. You're expected to increase your prescribing scope, and you're also expected to increase your sphere of influence. And the core advanced level is aligned to the NHS England ACP framework. So if you do that through the CPP route, then you do get the digital badge like Claire said that she got. But if you do credentialing on your own without the CPPE supported route, it isn't linked to the digital badge. Next slide, please. And this slide just links back to what we were saying at the beginning about the difference between the advanced pharmacist and an advanced clinical practitioner. So if you credential through the RPS, you are credentialing as an advanced pharmacist, not as an advanced clinical practitioner. The bit in dark blue in the middle is the bit that is common to both roles. So they're both working at an advanced level of clinical practice. They're both experienced practitioners working across the 4 pillars of practice, and they're both delivering complex care autonomously. But an advanced pharmacist is a role that would not be able to be performed safely, delivered by another professional group. And it's harnessing our... medicines expertise. So pharmacy and medicines expertise within a pharmacist specific capabilities. So it's harnessing those pharmacist skills. And tying into what we said, that was said at the beginning, saying that ACP has peer support from a variety of professions. If you undergo credentialing, there is an expectation that you would have educational and supervision and a mentor, which can be from other professions. We don't expect you to just get collaborators from pharmacists. And if anybody wants to look at this in more detail, it is in the advanced credentialing framework, which I think there's a link to on the final slide. So that final slide, please. I won't go through this, but if anybody's interested in looking at this, it's a table that can be found in the credentialing annual report, and it shows you from people who have assessed these e-portfolios what you should be doing to optimize your chance of building a successful portfolio. So the current report that's on there is for 2023. The report from 2024 is likely to go on about April time this year. But it just, if you're thinking about doing this, and anybody can open, any pharmacist can go onto the RPS website and open an e-portfolio at the level that they're interested in at any time, and start looking at that and building that. You don't even have to get as far as submission, you can just look at it. So yeah, so that's something that if you want to have a look at, that is in there. And I'll, conscious of time, so I'll stop there for you. I think the final slide has got the recent things on, hasn't it?
Oh, you're on mute, Tamarine.
Thank you. Thank you, everyone. We're a little bit over time, but I've just picked out one question that I've seen come in. That's I think quite a few people are a little bit confused about. So I think we just concentrate on that one at the moment, and then we will do the document and get back to everyone on the other questions. So there's a lot of comments in the chat around the CPPE supported badge route and the RPS as a credentialing route, and sort of what's the difference in that.
Shall I talk about the portfolio?
Yeah.
So when HE announced they were going to be doing a portfolio route, this is for all professions, the pilot was initially with RPS and CPPE, and that was the first 300 places that were funded. So essentially it was a funded route to be recognised as an advanced clinical practitioner with support from RPS and CPPE. So if you still go through that route, you will be recognised at the end as the equivalent of an advanced clinical practitioner. Alternatively, you can go through a portfolio route that isn't that, and you would be allocated a HEI in the same way if I was a physio, for example, or any other profession. And it would still be a similar process. It would be slightly different because it wouldn't be RPS and CPPE. So you can do either of those, and that's the expression of interest that is continuously open. Historically we don't have many pharmacists signing up to that. When I look back at the most recent cohorts, I would encourage, if anybody wants to do that, put your expression of interest in early. Like I said, it may take some time to be allocated, but it's good to kind of have that expression of interest in there. Obviously, yes, as Rachel said, if you want to do credentialing yourself, you can do that. I mean, the difference there is obviously you're not asking for your employer support, perhaps. It's not going to change your job role, perhaps, whereas an advanced clinical practice route or role, we would expect, you know, through the training or through the portfolio, you're showing your progression in a role and you're at a particular level, if that makes sense. I don't know if I've answered that very well. It's a little bit convoluted at the moment, I agree. I think it's got a little bit grayer because the funding allocation for the supported route has been reduced. Obviously, there's lots of financial constraints going on with NHS England at the moment. So I did just encourage everybody to look at what is most appropriate for them. Do you need a training route, i.e. would you benefit from going on to an MSc, or are you already working at that level and you may need just a support in a few different areas, of which a portfolio route would be appropriate. If you're not interested in having an ACP title or utilising the digital badge, I know somebody had asked that in the chat about I found it useful because then It's a recognised title, it's recognised wherever I work, that will go with me. And particularly working in primary care where I do, an advanced pharmacist practitioner is also reimbursable via ARRS. So it was kind of essential for me to show that I was working at that level. But if you don't need that, if you don't require that and you want to do credentialing, you can obviously do that as well. Yeah, hopefully that sums it up.
Thanks very much, Claire. So I'll bring the session to a close. I hope that that was really interesting and informative for everyone. We will share the slides and the recording, and we'll make sure that we answer all the questions that have come in the chat as an accessible FAQ document. So please, could you write any more questions if you have any before you leave? There'll also be a link to a feedback form coming as well, which will be popped in the chat as we speak, and we'll send that out to you as well via email. So thank you very much, and thank you to all our speakers as well for presenting today.